Slack was down and I wasn't able to get to the like the legit one on Monday or Tuesday whenever you ran it.
Mhm.
There was a slide in the presentation where you gave a overhead press with the feet on the wall, and I was curious as to like why you like specifically cued the foot reference on the wall. What's that doing?
For sure. So the number one thing I see with overhead press is that they have a tendency to overarch. They're going to find lumbar
Okay.
extension for shoulder flexion.
Hmm.
So, especially as someone who's regaining shoulder flexion, they haven't patterned the proper, scapulohumeral rhythm necessarily yet. So, by placing their feet on the wall and having them press their heels into it specifically, they are not going to be able to cheat as nearly as much as if they were just having their feet on the ground. They're not going to be able to arch. So, I find that's like an incredibly helpful constraint.
Okay. Yeah, that's really cool. And so I've been having like actually quite a bit of success with just recently with like changing positions to achieve the stack, and it's like starting to send some light bulb moments off for my clients, but also for me from a coaching perspective. But I am curious because obviously there's some different schools of thought with like the position of the pelvis. So PRI is very much like, tuck the pelvis under, posterior pelvic tilt. And it makes sense in the beginning because it's going to just facilitate an easier way to get the stack. But then you have, there's a different school of thought. I believe it's called like Pillar Principles. The guy, it's like a really trendy name on Instagram. I think his username is Flowbility.
Hmm.
Um, I don't know if you've seen it, but it's like, to me it's super super interesting, and it's honestly like it's really just looks like the stack, except they're not posteriorly pelvic tilting. They're saying like keep a tunnel of between the low back and the floor, because when you're moving through space you don't have the floor as a reference point. It makes sense to me, but what I'm wondering is, it like in my head, this the way like Zach Couples and Bill Hartman and you and like the PRI way is teaching the stack, that to me seems like a good segue into being able to achieve the stack from this position of what the actual like honoring the spine's natural curves. Like,
Yeah.
do you know what I mean?
Absolutely. Yeah. I think it's the idea of if someone is really far in one direction, you want to push them really far in the other direction so they end up somewhere in the middle when they stand up. That's kind of what we're doing here. And I think it's really hard for someone to teach them to get out of their, or like, I hate the word get out of their extension pattern because that's like, you don't want to be there, but you do.
Mm-hmm.
So, like, to gain variability from their extension pattern, it's important to teach them what the opposite of that feels like. And I feel like if we never did that, I would have a really hard time believing you can regain variability effectively and get the diaphragms to work synchronously if you're never going to teach that person what the stack is in the context of like how we talk about it. I have a really
Mm-hmm.
hard time seeing how that would work. Maybe you could, I don't know, because I've never really seen this guy or seen him do his drills. But I just find, if you just do a slight tuck, because you can over tuck, but if you
Yeah.
do a slight tuck, that is just going to go so much further for just, simply taking stress off of someone's low back too.
Mm-hmm. Yeah, I'll tag you in some stuff
That'd be
and
great.
on Instagram, and then you can just kind of maybe we discuss it in our next call or something. But it's like, yeah, I'd like taking ideas from different schools of thought, and it seems like PRI comes at it from this perspective and they come at it from this one, and both people are getting results. So I'm like, I'm curious to see like how it meshes together, you know?
Definitely. I'm glad you're doing that because I was I was watching a Bill Burr stand up last
I
night.
love that
Yeah, he's
guy.
really funny. He's like his old stuff is really good too. And
Yeah.
he was talking about like, like he's talking about like different races and like different cultures, different backgrounds and all that stuff. And he made a really good point of like how each person from a different part of the world, like each culture misses something. So like they're really good at certain things, but we're all missing something. And he was like using, for example, like white people don't know about lotioning their skin or whatever. And it's
The
like, we don't
ashy.
know. It's ashy, right? Yeah. Like we don't know about that.
Yeah.
But if we did, we would become more complete as a culture. So I think PRI does things one way and that guy might do things another way, but we might be missing something that that guy has.
Yeah, I'll tag in some stuff and then we can chat about it. Thanks.
For sure.
I have a quick question, and
Right.
uh if it's okay, if I ask it.
Please.
I was studying the slides yesterday and noticed that with the second case study, in the phase one, you didn't have this particular client have any upper vertical push or pull, even though like one of his like in his shoulder like flexion was like 120 on the left and then 90 on the right. And then, but then I compared it to like the other two case studies, and like you like in their phase one, you integrated vertical push and pull, even though that their shoulder flexion was measurements and their initial assessment was similar. What am I missing?
So this particular individual, let's pull up the case studies for some context here. Amy, that's a really good question. And it comes down to just who the individual is at the point in time at which we are, programming for them. So, okay, come on, slides. Okay, was it this guy? I believe it was this guy, right? Yeah, okay, so this dude, it was this guy. And this is one of the most broken people I've ever worked with, just biomechanically. When I first started working with him in terms of just like all things considered. So if we remember what this guy's intake form looked like, it was pretty crazy. And the guy's had everything hurt on his body. And for me to give this guy, and he also had like this clear torque and extension pattern. He was like laterals all over the place. So I just didn't feel like the risk versus reward of giving this guy an upper vertical push and pull was worth it for this person. Like I would rather, especially because honestly, it was during COVID. Yeah. So it was like at the very, very beginning. So the dude didn't really have access to much equipment either. So I just was like, you know what, like, let's take this so incredibly like safe rather than sorry, because I don't want to give him anything that he can't handle. And if he has like this weird lateral orientation and his shoulder flexion is like drastically different, I can just see many, many scenarios in which he would compensate heavily. And I don't think I wanted to go there with him where it was like, okay, I want you to do, a wall-referenced incline press on your left arm and not your right arm. I just didn't want to like make things too strange at first. Whereas for someone like, I don't know, this is probably a better example. This guy's coming from a powerlifting background and his shoulder flexion is really terrible. But I'm having him do a half kneeling alternating landmine press. And actually what I had this guy do was back away from it. Because if you move your body away from the bar, you actually end up pressing much more shallow as opposed to if you're close to the bar. So that is just me giving this guy a little bit of, because this guy hadn't lifted. He hadn't trained really for, I don't know, it was at least 6 to 8 months before working with me. So I just wanted to get him back and feeling a little bit. It's like it's kind of tailoring it to this person's personality a little bit.
Okay. All right. Thank you so much.
Of course.
Connor?
What's up?
I have a question. Maybe this goes under the advanced program that you're thinking about. You have a webinar with Hala. Is that her name? Haley Kava.
Oh, Haley Kava. Yeah.
Pelvic floor dysfunction.
Yes.
I'm just curious if you, in these 12 weeks, are going to mention something about pelvic floor dysfunction, since it's, in my field, is a big problem. I work with athlete who has given birth to 1, 2, 3, and also constipation. She talks a lot about it, and I think it's very, very interesting. And I know that we can fix a lot of these stacked problems with just giving your corrective exercises. And I have actually had success with that with one athlete, a master athlete, cried out on the field, didn't pee and did kind of like a lot of sprints. But I'm just curious if you're going to talk about it. That's my question.
I'm glad you brought that up. I'm absolutely going to tackle it in the advanced course in the lower body advanced biomechanics. And then once we get into the I believe it's the more advanced correctives. But honestly, if I'm being totally transparent, like just PRI actually has a course. They have Myokin, where they talk about the lower body a lot. They have pelvis, which is the Myokin is like the left AIC, and then in PRI they talk about the PEC, but really, and also pelvic floor dysfunction. So in pelvis, they're using very similar exercises as they teach you in Myokin, and really like most PRI courses have like the same exact exercises, just used in different contexts, explained in different ways. You probably know what I mean. So
yeah, I do.
It's the same exact thing for what I would be talking about.
Yeah,
like
you have the concept.
I think if you just took them through all the phases, you would probably see a lot of success. And I think the only difference would be between this and when I talk about the pelvic floor in the advanced course, it would probably just be more like, hey, you probably want to, if this is what their true issue is, you want to start incorporating Kegels at a certain point, which is once you get their pelvis in more of a neutral state. You don't want to do Kegels right out of the gate. And also you want to make sure that you're getting a little bit more asymmetrical a little bit earlier, because that actually plays into it a little bit. And there's just like a few more nuances, but ultimately, if you just gave them the things that address their pelvis and made it neutral, that takes care of 75 to 80% of all this pelvic floor stuff, if not more than that, honestly.
Yeah, she did some 90-90 sideline knee slides and some kind of knee to knee exercises, and she did some 90-90 hamstring bridge. Also some exercises. I think that PRI, and sorry if you can hear my daughter screaming outside.
You're good.
And also some exercises done from David Gray. I know you know him from your podcast. Yes, he wrote to me, "You're a fucking genius. Thank you. If I did go see OBGY, I don't know the American name for a gynecologist. Yes.
Yeah. I think that's what it is.
OBGYN, obstetrician gynecologist.
Thanks.
I know that because I'm a girl.
Cool. She wrote that they would just say, yeah, you have had 3 babies, so just learn to live with it, kind of. And that was like, we can do the manual approach. That would be one way, and we can also do the corrective exercises. And then she wrote me last week that she ran and did some hops out on the field for 60 meters, like 4 times, and then she did a lot of sprints, and she could feel way much more power, and she didn't drop one drop of a pee, and she was like crying out there, and that was amazing. And you know, the sentence is that, can this really be true? I mean, yeah, kind of give the body what it wants if you haven't, because she's really strong, but she has struggled a long time. So just want to share it, and thank you very much. And then I just want to hear about the organ situation in terms of the biomechanic, because that fits very much into all this. So yeah.
Most definitely, man. And I'm really happy that you shared that. That's really an awesome story. And I think honestly, pelvic floor cases are some of the most just rewarding we can do as coaches. And as male coaches, it can be a little bit hard because like females don't necessarily feel comfortable talking to us because we can't understand, because we aren't females. You know what I mean? But I think once we do get them to open up and they do feel comfortable, it's very much like a rewarding process for both people. But really, like the pelvic floor, if someone is in like a forward anterior orientation of the pelvis and their pressure strategy is off, meaning that most females are more on the spectrum of narrow, obviously not all at all, but a lot of them are. So if you're forward and you're kind of a descended pelvic floor and you've got a pressure strategy where you don't have your stack, and then all the pressure is going forward and down because you're also compressed anteriorly. So you got to think about like, where's the pressure going within the pelvis? Well, when they inhale, it's going down. It's not going into the rib cage to expand it, especially because a lot of females have these secondary compensations. So what's going to happen with this descended pelvic floor is you're just going to push this pressure down. So incontinence is often this outcome and result of a pressure strategy where the pressure has nowhere to go but down. So when they have to absorb force when they have to produce force, they can't really do that effectively. So the pressure just gets push, push, push. And then you couple asymmetry on top of that, and then you can have an even more torqued pelvis. And a lot of the times when you're forward and down, that pressure is going directly in the bladder and then out the urethra. Like that's just, that's really what it is, just a poor pressure management strategy. So really stack would still be the number one goal. And I'm sure that you address that with your patient. Also, Brian, thanks for bringing up Jill. Jill's awesome. I've actually recorded a podcast with her, but the audio didn't work. That was definitely my fault. But she's awesome. Couldn't recommend her enough. And I actually kind of wanted to take her course whenever it runs again. So you guys should definitely check it out. I might see you there.
Just like a helpful hint for like dudes working with women with pelvic like floor things or like postpartum stuff. Okay, just because like you're a girl and you're working with another female, if you haven't gone through that kind of process, the way like it is harder to relate, like because I've never had kids because I just don't. And the way I've approached it is that I have to think of childbirth, pregnancy, postpartum. That is trauma. That is a traumatic, it is one of the most traumatic experiences on a female's body. And so approaching it as if it's injury and trauma will allow you to connect with it better.
Mm-hmm.
If that makes any sense.
That's a real, thank you for saying that. Thank you. Yeah. I think that's a perspective that, yeah, I struggle to fully understand, you know, like, cause that is traumatic. And yeah, I do too, because like I'm never had like the inkling. I'm not one of those people who's like, oh my God, I want to like have babies. I'm not like, I think something's wrong with me because I'm a girl and I don't feel that way. But I still have to work with this population because I'm just a female and they want to come work with another female. And so that's the way I have to think of it. And because I understand y'all's perspective, like, oh, that's weird. Like, I can't relate to that. But, you know, just, yeah, like it's injury, it's trauma, and approach it like that. Most definitely. Yeah. And I think just not even like, if you sense that's going on with a female, I don't usually bring it up right out of the gate. Obviously, I think it's important to establish a rapport, but there's been 2 or 3 times where I knew like that's where this person was coming from and they knew it was going on. They just didn't want to talk about it because they felt embarrassed or whatever. And so what I actually ended up doing was referring them out to a female that like Haley, who has pelvic floor experience. And I think that requires us to like, you know, hey, you're not paying me anymore, but like, what do we care about? If we care about this person getting better, I think referring out is something we probably don't do enough. I wanted to talk about something before it gets too late in this, that I've been having a lot of thoughts. I've been talking to a lot of people, and these lateral orientations are just so challenging. They really are hard. But the thing about laterals also is that once you see them, it's like when you're trying to buy a car and you start seeing the car you want to buy everywhere. It's kind of like that. And I very much am seeing these lateral orientations more and more over the past, 4 or 5 months. And it's really interesting because I can't fully wrap my head around why this is so common, but I think a big reason why it's so common is because we're trying to find the right IR. And many, many people, the more like I start taking femoral measurements a lot more because I'm starting to notice like a lot of people don't have right IR. And consequently, the lateral orientations have just a really hard time getting them to, like, I've had cases where I've given people the left AFIR, given them push back to the right, then the left AFIR stuff. I've messed around with a lot of different variables. And what I notice is that people taking care of like a pinch in the hips, you often see a right hip pinch, but then this left hip also pinches. And it's also really hard for people to get this hip to stop pinching. Because what you see an extreme lateral case, and I'll talk about this in the advanced course, where they go up and over like this, where it's like they're no longer lateral, but they're no longer oblique either. They're like a combination of both. So then they pinch here as well. So I think at that point, we need to start considering like creating space within the pelvis, like literally changing, like as Alex Epper would say, changing the shape of the pelvis. So when we go and we try to do these exercises, these people have been in this pattern for quite some time, most likely. And a couple of positional drills sometimes just isn't enough to get them to actually literally get their pelvis to move out of this locked up state. So a couple of things I found to be very successful are, we need to get them to basically, ooh, I almost slipped on my rug there. We need to get them to push this down with some force. We need to have this come back like that. And we can do that by applying force to the top of the ilium. One way we can do that, like perfect example, I had a guy in the last biomechanics group, and he would tell us, like, I can only feel significantly better if I lay on my left side and my wife sits on my hip for 15 minutes. Which I think that's very interesting, because what he's doing is he's doing this. He's laying on the floor and he's doing that. So maybe if we start to apply a little bit more direct force, we can actually create a shape change, because this person is probably struggling to do that without a reference to do so. And like, they're just jammed up. That's why manual therapy can be so helpful. But a lot of us as personal trainers, we cannot do manual therapy. So how do we do that? We can do that a couple of different ways. We can literally just have them lay on their left side. And we can do that by placing, what I would probably do in that circumstance is have them lay with something like a pillow underneath their left waist, and then place something heavy, like have someone sit on them. That can be an effective strategy. Something else we can do is, I need to get a foam roller, but grab a foam roller and literally just lay on the top of that ilium and roll back and forth. Roll, roll, roll back and forth, and just sit there for about 5 minutes and open that area up. And then retest. If their straight leg raise improves, or if they have some sort of like better femoral internal rotation, then we know that we've created that shape change. But it's then important to then go and do those exercises. Another exercise I find that's really important, because with laterals we need to push back to the left, is a position like this, where they're laying on their left side. Let's say this chair is my wall right here. This is like a sideline prone right propulsion drill, where they're here and they're here. And then if you can get them to push their right hip forward a little bit and drive that right arch into the wall and get right through the max. Let's just all do this together right now, if you guys don't mind. Let's hop on the floor and let's do this so that we can sense it. So you want something underneath your left waist. I'm using a book. But you don't want it to be so far underneath your left waist that you can't feel your left hip being pushed into the floor. Because remember, we don't want these people necessarily expanding their left abs. We do know that they do have a higher left side, but that doesn't mean that they have left abs, right? That's still something we need to give. We need to give them those left abs in a position where their pelvis is not in a lateral orientation, which is what we're doing right here. So if you drive your right arch into the wall, you should feel your glute max kick on. And then reach forward with the right arm to help drive you back to the left. And then your left knee should be at 90. Try to lift it up slightly for some left adductor. And then breathe right there. Drive that left hip into the floor. You should feel right glute max, left adductor, and your left hip pushing into the floor.
Connor,
Yeah.
I've done something similar to that. I was just kind of like, I'm trying to, anyways, doesn't matter. I did something similar to that from like a, basically a quadruped position, but instead of, so I'm in a quadruped, my one, doesn't matter what leg, my one leg's extended behind me and it's like I got the heel reference against the wall. And then I'm on my elbows and I'm just protracted and I'm driving through the, yeah, like right glute max because I have the heel reference. Is that kind of similar or how would that be different?
The prone right propulsion drill, like this one right here.
Oh, maybe there's a name for it.
Yeah, this
Yeah.
right here.
That's the one.
Yes, this is essentially the same thing, but you're not getting the shape change within the pelvis as much.
Okay. And can you just explain, like, this is where I'm trying to still figure it out, is like I'm trying to see through the flesh, like when you're doing an exercise like we just demoed, like what's going on in the pelvis, why would you do it? What would be the reason you give it to somebody?
So remember what I explained about laying on the floor on the left side?
Yep.
You're getting that. And then the right hip is being pushed over the left via the right glute max. So from the back, it looks like.
Okay.
Yeah.
So you're just getting that right hip to come forward.
Mm-hmm.
If they present like that, like single knee to chest or straight leg raise is more, or single knee to chest is more on the left side.
Yeah. Yeah.
Oh, all right, cool.
Yeah. And then whereas on the other one, you're still getting this, but you're not getting as much of the left hip.
That's right.
Literally pushing down. One thing actually, Tyler, I'm glad you brought up that position. The hardest thing you can do is incorporate a right glute max, a left adductor, and right trunk rotation, which is literally the inverse of the left AIC pattern, because left AIC pattern, left glute max, right adductor, left trunk rotation. So to drive that, PRI likes to use a side, like a ground base. There's easier positions than this, but just to illustrate how difficult this can be, is you're here, right glute max activity, but then you do right trunk rotation like this. This is the hardest activity, like ever. It's so challenging to get everything together. And it takes a lot of practice to be able to hold this together. I rarely give it out, but when I do, it's pretty effective. It just takes, I've never had the trunk rotation component until I've been doing this activity for like 2 weeks.
And you're lifting that bottom knee off the floor?
A little bit, yeah. It's like a knee to knee.
Okay.
And then something you can do in that position you just mentioned is to get that rotation passively in the trunk, you can just do this. I may have shown you guys this activity already, but I think it's really good. Where I probably use more of a book, more higher book under this hand, but you're getting right glute max, left adductor, and you're also getting that right trunk rotation. This is a really good drill to get everything sort of cinched up.
Okay.
I have a quick question. So you had the book not underneath your waist, but underneath the hip. Not here, but here.
I had it underneath my rib cage a little bit.
Right here.
But I'm still pushing my left hip into the floor, because if you have it too low, actually, if you have it like down here, then it's hard to sense this top of your ilium pushing into the floor. So I put it more up here so I can still get this, but also drive the left hip in the floor.
Okay. Okay.
So I think those are just a couple of considerations for these laterals. And there is also a world with people where, and I'll talk about this much more in depth in the advanced course, where they're so lateral that they start to get up here, but then what ends up happening is their pelvis actually starts to orient back to the left, like their sacrum. See how that could happen? The sacrum starts to go left a little bit. And those people are like a right AIC. They present as that. And they're rare, pretty rare as far as I'm aware, but they do exist. And we'll talk about that later. But that's a different story for a different day. But I would just encourage you guys, if you're having a lateral and you're going through all the phases and it's not really seeing results, consider some of these techniques. And then I really like that one I showed you, the sideline one, for getting them to push back to the left first.
Hey, Connor,
What's up?
can I get your opinion on something similar to that sideline one?
Mhm.
I used to do that one a lot because I would go to see a PRI person and they prescribed it. What I've been doing lately is doing like a right single leg glute bridge. Inside edge of my right foot to kind of rotate over, support my left here, and then can you see? I push my right hand into my left knee. And then I do like the breathing and everything there. So
That's not bad at all, man. That's not bad at all. I like that. You come up with that yourself?
yeah, just by like looking at a bunch of different stuff, I guess.
Yeah, man. It's all about the principles. And I think you nailed it. So I think that's awesome. And that just goes to show that you can make stuff up if you want, as long as it's effective.
Sweet. I feel like I have a little bit of a lateral orientation. I can tell when my hips are kind of rotated that way, and that one gets me out immediately, basically.
Yeah, I think that's sweet. That's a good one. I might play around with that with some of my clients, see how they like it.
Sweet.
Anyone else? I don't know. Either Ryan, go ahead first. I think I heard you first.
Yeah. So I got one quick one, two quick ones. One was, when you're doing that well-referenced Arnold press, can you do something like a Z press? I know it's not quite as easy, but would it work the same way if the person has like shoulder flexion, basically?
A V press being like a Viking press?
Sorry, a Z press. I mean, we can do
a Z press.
Yeah, like sitting. I like do it with a little step under their butt so they can not be quite so down, but they're like here basically.
Most definitely you could. Absolutely.
And the other thing I was going to say is what you were just talking about, that guy with like his wife sitting on his hips. So I saw something that Jake Tura posted, and I couldn't find it because I think I tried to save it, but I didn't find it. And he like basically had sandbags on his hip.
Yes.
Pushing him down. And it was like, I think it was physically creating, like opening the pelvic outlet, getting you like, and he had like more internal rotation when you test and retest it afterwards. Like he did both sides with like 100 or 150 pounds or something. And like, do you think that would be a good strategy for, especially because he's like a big, strong guy, like someone like that?
100%. Yes. And I think that's a really good way. And honestly, I've been thinking more and more on how can I get these extremely compressed people to, down regulate and like get some variability. Really good way. I would just make sure that I did some drills thereafter to make sure we can then actually have them own some positions. And you do have I find that stuff lasts for about, if you did it for 15 minutes, you're probably looking at 15 to 30 minutes of that stuff sticking. So I think it would be important it's obviously going to stick longer than that, but just like the true, like the most bang for your buck is going to be in that window.
Gotcha. Okay, cool. Let me try that. Yeah, go ahead, Phil.
Thanks, man. Yeah, Connor, we had like a Skype, a one-on-one Skype talk maybe like 2 weeks ago where we're talking about the side lying adductor drawback. And that's a drill that I really swore by for a couple months. But I was looking for a way to kind of amp it up a little bit. And then you recommended a drill where I'm kind of on my stomach. I get like a reach, so I protract, and I get that right heel against the wall. You know what I'm talking about?
Could you get in the position by any chance, or do you not have enough room in your room?
Yeah, I have, yeah. Yeah, like
Yeah.
Look at this.
Yep.
Get like a reach. And get that right heel against the wall.
Mm-hmm.
And I get that left adductor fire.
Yeah.
You know what I'm talking about, right?
Absolutely. That's that prone right propulsion drill.
Right. So what's the difference between that drill and the one that you just showed us where I'm the one you just went over?
The sideline one?
Yeah, the side line with the right heel against the wall, but you're lateral instead.
Yeah, that's literally just the amount of pelvic shape change that you can get. So if you're laying on the ground, you're going to be able to get this to happen more if you push that ilium into the floor. And then you can push your right hip over your left to facilitate that right hip coming more forward. Whereas on the prone right propulsion drill, you don't have the ground reference. So that's much harder to happen. But what you are going to get is when you drop that right hip lower than your left, which I find is easier to do on that activity, you are going to have that occur more, which can be very beneficial because you're also actually going to get a little bit of a posterior hip capsule stretch in that if you drop that hip to a meaningful degree, but you obviously don't want to overdo it, right? But in that position, I find it's much easier to get a posterior hip capsule reference, which can be very beneficial for the right person. These lateral orientations oftentimes have been so far up here that they haven't sensed their posterior capsule in a long time. And there are a couple, like I mentioned the other week, I think, I've had 2 people where giving them a posterior hip capsule stretch in AFIR is the most effective thing that we've done yet. So it's just, a lot of it's trial and error, man. A lot of it really is, if I'm being totally honest. Like the principles are there, but you got to keep trying stuff and seeing what improves the test results the most.
Right. So another thing I want to mention is, it's not really a question, but those assessments, man, really bang for your buck. Like I know you briefly spoke about them in like IG posts, and like you're kind of giving snippets, like little bits and crumbs, and now with this course we're really getting like the full decked out assessments. But it's just once I get a better grasp of all these assessments and exactly why I'm doing them, or at least have like 1 or 2 reasons why I'm doing each assessment, off the top of my head without having to like look through my notes while I'm talking to the person, like I feel like I'll be able to generate so much, get my clients to really where they really need to be, you know?
Absolutely, man. Absolutely. And if you just simply looked at it as if hip flexion is an external rotation and expansion test, straight leg raise is an internal rotation and compression test, things start to click a lot more. But yeah, man. And I think because you went through things, like you did one-on-one with me for like 6 months or so, just like kind of on and off for like 2 weeks at a time. I think, yeah, you've been through it. So you know what it's like to sense things, and you know what it's like to coach it as well. I think that's extremely powerful. I think that's the best thing you could possibly do.
Yeah, I think we're going on close to a year actually, man.
Yeah, man, it's been a while. It's been a while. Yeah, Phil's one of the OGs with me for sure.
Yeah, man. But let's say for example, like I'm starting to like from a marketing standpoint, and like you know, a lot of coaches will have assessments, so they'll tell people, hey, I'm playing around with certain like variables as well, but let's say, for example, you're working with someone overseas, like they're not even, obviously what's going on, like everything's online anyways, but let's say you have let's say you sell your coaching, but let's say anybody sells their coaching, and you obviously include a program because they'll fill out like an assessment form. But even before you even provide the program, you want to see like what the restrictions are. So you'll tell them, for example, hey, like I need to be on Skype with you for a good hour. Like, what I'm trying to say is most people don't understand these assessments. So it's like and these assessments can be very easy to cheat as well.
Most definitely.
And general pop people, they don't know this kind of stuff. So because a lot of the coaches don't even know this kind of stuff. So so I'm just thinking of like restructuring the way I'm marketing myself and the way I'm coaching people. And I think in my personal case, and a lot of other coaches, it'd be good to have that 1 hour assessment on Skype, where I could like really go over these drills one at a time, toe touch, squat, all that kind of stuff. And and from then I'll be able to have enough I'd be able to gather up enough information to be able to really write the right program.
Yes. And I think the fact that you said an hour is really, really good there, because what I do with mine is I offer a half an hour free consultation where I just say, hey, like, let's get to know each other. Let's see if we're a good fit to work together. No strings attached, but I'm going to assess you and I'm going to see what's up. So what I do, I assess them, I go through everything, and then I explain what they're doing with the pelvic model. But I've started to refine the language I use when I talk to people about their assessment results. I used to, at the very beginning of this online thing, go like the whole thing, right? You're a wide ISA. That means you're biased towards this. By the way, everyone's right side dominant, so everyone's also biased towards this. And then I would try to be as thorough as possible, but then I just lose people. It wasn't like an issue, but it was also like, this is a lot of information. So I don't even talk about ISA anymore with my clients. And I just talk about like this is where your pelvis is. This is why you feel this. Remember how you didn't like this side was more than this side, or you feel like this. And then like I have them palpate their ASIS. And that also is like an objective indication of like, hey, your left hip is higher or your right hip is higher. And that makes sense because they can literally feel it. I think the more things that they can actually literally feel and have you explain those things, that goes a really long way. And that will come with reps. But yeah, man, I think that's an interesting point you also made about marketing and how you can use that as a way to, I guess, make yourself different. Or I'm dropping the word here, but a way to make yourself a little bit unique. I think that could be huge.
Connor, there was a podcast. Actually, do you have like a lot of stuff to get to, or can we keep asking questions?
Dude, for sure. Yeah, let's do it.
Okay. There's a podcast with Zach Couples. I believe it's all about the rib cage. I think it's that one. And he's talking about the shoulder assessments, the abduction and adduction. I'm kind of a little, and he talks about like the fibers, like the orientation of the fibers and how they will tell you like where they have a hard time or easy time getting air into the upper portion of the thorax. From what I understand, like very simple way is like, this is going to kind of test, like, can they expand into the backside of the thorax? And then this way is going to be, can they expand into the front side? But I think that's pretty simplistic. If you could like kind of just, what do you think about when you see that?
I used to think that was the case, but the more I think about it, the less on board I am with it to a certain extent, because he talks about the rotator cuff fibers and the orientation of them. So for example, I believe it's the subscap has fibers that run oblique, and that lines up with other rotator cuff muscles, but it also has horizontal fibers at T2 and T4, whereas the other rotator cuff muscles, like the infraspinatus and the teres minor, they don't necessarily have that. So the horizontal orientation of those fibers, actually, if they were concentrically oriented and very tight, that would, in theory, limit your ability to go into horizontal abduction, because that's basically the same orientation and line of the fiber pull. So if they're tight, it's going to prevent the scapular movement needed to go into abduction. Now, the other thing he talks about is if those fibers are also tight, you're also going to have a hard time going into adduction here, because you're not going to be able, and honestly, I'm not fully, this is where I also get a little bit like, because it's only like a couple of fibers on one muscle. So that's where I'm like, but also he talks about the oblique and how if you drew a line from here all the way down, that would line up perfectly with the fibers of that subscap and other rotator cuff muscles that share the exact same fiber orientation. So if those are tight and they're pulling you down into more of a scapular retracted position, then you're going to struggle to get into this. Likewise for this, but also it's like a rib cage thing too. I think it's more of a rib cage thing than the rotator cuff fiber orientation, because like in order to go into internal rotation of the shoulder, for example, you've got to be able to start from a place, because if you're starting here and in internal rotation, then you're going to jam and you're going to get stuck, right? Like you can literally just do it right now. Go here, try to go down. It feels terrible. It feels terrible because you're already compressed and being pulled forward here. Whereas with external rotation, if you're already pulled back in your shoulder, you try and go into ER, it's really, really hard. So you feel that restriction, right? So I think it's more along the lines of like the compression of the rib cage and how that affects your scapular position, therefore limiting yourself, because you can't get somewhere you're trying to go if you're already there.
Okay, so when you do your shoulder adduction abduction tests, what are like what are some of the one or two things off the top of your head that you're looking for?
With adduction, I'm looking for them to keep their posterior, like this upper border of the scap right here, glued to the table or whatever we're using. So I have them literally palpate it before they go down, because adduction is honestly the hardest measurement to take online, at least, because people don't know what that feels like. And people will be like, okay, do I feel restricted here? Like, am I rolling too much? People will roll and they're cheating if this exact spot comes off of, if that comes off of the table or floor.
But
Then
then what
they're-
is the finding?
The
Like, that's-
finding would be upper rib cage restriction, T2 through T4. Whereas abduction is 5 through 7. And then you also have internal and external rotation, which are 5 through 7 respectively, of posterior and anterior.
I have a quick question. On the slides you listed for a corrective for this the third case study, you listed a hook lying hamstring bridge with dynamic marching. How does that work with doing breath retention?
For sure. Yeah. So in that position, the reason why I gave it to him is because he's an athlete, wanted to add some dynamic movement. And honestly, I don't really cue that up with the breath too much, especially for an athlete. I can just get a little bit too much. So as long as they're breathing controlled through it, they're feeling their obliques on, and they're keeping that slight contraction as they inhale, and they're just going through it and controlling it, I'm totally fine with them just going through it.
Okay, because I tried to do this morning with breath retention, and I was like, I must be doing something wrong because the rhythm isn't correct.
Yeah.
Like, yeah.
I totally know what you mean.
All right. This kind of goes back to the assessment one, where even first, like, I'm only speaking for myself, but like, even as a coach, like, I feel like it's hard to grasp like some of these assessments. And I notice you always take out what biomechanists would call the Elvis the pelvis. You know, you just take it out and you do your movements with it, and it helps get your point across to the client. And I think it also helps yourself like understand even more. Like, it's more like visual, tactile, all that stuff. I'm looking for a skeleton, like a life-size one, but not just any in particular. I'm looking for one where I'm able to assemble and disassemble, like, very, if that's a word, very fast. So it's like, I have, let's say if I have it's like 6 feet tall, and I just want to have the pelvis. I can just take it out. Like, this isn't just for you. This is for anybody who's like who knows about like or recommends like a skeleton life size, not too complicated. You know, you want to just work with the lower body, you could just take them out, like take the femurs. You want to work with the head, neck.
Most definitely. So I know that I've never bought one, so I'm probably not the best person to know about that. But what I will say is I know that those big skeleton models are quite expensive, where that's why I kind of went with the pelvis when I started off, because like it's easy to access. And so I got like those, and it wasn't too bad. But the place where I got all of my stuff is off of this site called 3B Scientific. I honestly really recommend them a lot. I'm very pleased with all of the products that I've gotten from them. So let's see what they got.
Right.
Here you go. There's actually, these aren't too bad. Here's something, a disarticulated human skeleton, but I don't know if that would hang. But yeah, these are actually not too bad. Although the ones that are nice, you're probably looking at upwards of $500, if not more. But hey, man, you know what? It's a true investment. And I really genuinely think that I could not do my job nearly as well as I can now without these things. So check out 3B Scientific.
Oh, sorry. I tried to look for the malalignment syndrome book. But I looked on Amazon. I couldn't find it. Where did you find that?
That's interesting, because I got mine off of Amazon too, not that long ago.
Oh, okay.
Yeah.
I was like, what? Because I didn't find it. So, but I'll look again. Yeah. So I was like, maybe he like bought it from like some like secret like website that I don't know about.
Ryan's got it. He came in clutch. That's it right there. Yep.
Where?
Only 2 left in stock.
Well, hold on. Let me get on that.
Yeah, I want to order it right now. By the way, I wanted to ask you guys: have we made any progress with the case studies with our small groups? How's that going? Because it's always kind of a shit show, and I know that people don't necessarily always come. That's why I combine groups. So I know in reality, really like 5 people are going to show up to that meeting.
Our group is meeting tomorrow at tomorrow at 1 p.m.
Great. Okay, cool. How many people have expressed interest?
Probably Ryan, Keith, Cam, probably about 6, I would say.
That's great. I'll take that. What about someone from another group? Do you guys have any updates on that? Fleming, how's yours going? Oh, you're with, okay.
I'm with Amy. Yeah.
Gotcha. Is
I was
everyone?
gonna ask.
Go ahead, Ryan.
I was gonna ask today if my group could meet tomorrow or this weekend. But besides that, I don't think there's been any talk about it.
Ryan, which group are you in?
3 and 4 or 2 and 3. I imagine it's 3 and 4.
Yeah, 3 and 4. Oh wait.
I think both Tylers are in my group.
Oh, so you're in 1 and 2 then.
Oh, whoops, 1 and 2.
Yeah. Okay. Hey, would you want to take the reins and just schedule a meeting for people?
Just send a message out in it.
Yeah.
Okay, perfect.
If you two could work on that together, I would appreciate it at time. Just like schedule it, like, hey, this is when it is. And then I'll see what's going on with 5 and 6. Actually, it looked like they're doing something. Okay.
Connor, I got a question.
Go ahead.
Okay. I'm a little, I'm going to go, obviously I saved all the slides. I'm going to go through the slides probably a bunch more times. But I just want to hear, did I learn better like this? So like when we talk about phase 1, phase 2, phase 3, like you definitely don't want to go to, don't want to skip. So like what's your main concerns in phase 1, main concerns in phase 2, main concerns in phase 3? If you could just like walk me through what you're kind of looking for, what you're going to, based on the assessment, and when's you're like, okay, we can move on. Like
for sure. Yes. So with phase 1, it is an expansion bias because compensatory strategies are actually strategies. So we want to just remove all that crap. We want to just get them to breathe better again. Phase 1, like in PRI, they would say establishing a zone of apposition, which is just, can you breathe and not breathe through your neck or your belly? So what I want to do in phase 1 is I want to restore external rotation, abduction, and flexion measurements. So I want to make sure their hip flexion non-compensatorily can get to 110, 120 degrees. I want to make sure their shoulder flexion can get to 120 degrees. I want to make sure that their external rotation of their shoulder is fully clear. Once they have those things, which honestly shouldn't be that hard, I will then move on to internal rotation in phase 2. Now, the exception to this rule is you have a narrow who has primary compensations and they haven't compensated secondary yet. But the reason why it works in the progression is because they're going to pass all those tests anywhere. So you can just go, hey, phase 1, oh, you're already there. Let's move on. But we have to be careful that they're not cheating to get those range of motion assessments done. After phase 1, we want to go to phase 2, where now we are trying to restore internal rotation, extension, adduction, internal rotation. And with that, I want to make sure that their straight leg raise can get to 70 degrees. If it's crazy, if it's 100 degrees, I want to bring that thing back to 90, 80, 70-ish degrees. I want to make sure that their Ober's test is being passed on both sides. I want to make sure that their internal rotation of the shoulder is then passed on both sides. But ultimately, through all of these things, we're going to see a discrepancy between the left and right side relative to that starting left AIC orientation. So if I have, for example, a goal to restore shoulder internal rotation and the left side is 70 to 80 degrees and the right side is 50 to 60 degrees, that could be a point where I'm like, we're probably okay right now. We can start to move on from that. So there are going to be these slight differences. That's why in the slides, I say you're going to see the right being better than the left or the left being better than right relative to what we're looking for there. Phase 3 is going to then be more of this left AIC. But the good thing is like by that phase, they should be feeling a little bit better. And it seems like it's a lot. We're going from like one phase to the second phase to the third phase, but ultimately like there are situations where the first phase is going to take 2 weeks, second phase is going to take 10 days, the third phase is going to take 2 weeks. And that's not really that much, but there are other circumstances, as you guys saw in the case studies, where the first phase takes 2 months, the second phase takes a month, the third phase takes 2 more months. So that's why I think, and that would be my number one recommendation for people just starting off with this stuff, is like follow those phases, because we'll talk about it more in the advanced course. You can actually do more than that under certain circumstances with certain people, but I just don't think it's worth going there right away. I think it's really important to establish the basics and get that done. And it's so hard if you take a step too far and then you have to tell your client like, oh man, I messed up, we got to go back. That's a tough situation. So that's why I think it's really important, like, get this. So they have this. Okay, then you can move on.
Okay, so just to recap, phase 1, you said they have expansion, like more of an expansion bias. You want to restore flexion, external rotation, breathing, like zone of apposition, and abduction. Phase 2 would be restoring extension, IR, adduction. You want to see like a single or straight leg raise about 100, and you want to pass their obers. And then the third phase, that's where I was kind of confused. You said it was kind of just like left AIC stuff, but what are you looking for to clear? What are you looking for there?
Okay, so on the straight leg raise, I'm more looking, if they had 100, I'd be like, that's too much. We probably need to give them more hamstrings to bring them back to 70. But, or like really, if they're at 90, it's probably fine too. But anything over 90, I start to go like, you have just long hamstrings. In the third phase, I'm starting to look for shoulder internal rotation to improve on the right. I'm starting to look for shoulder flexion to improve on the left. That tends to be the one, in my experience, that's the trickiest. So in the third phase, right trunk rotation activities are going to be important. But if you look at the exercises I gave you in the third phase, there are right trunk rotation activities. That stuff's already built in. You want to make sure that you're getting that left overs to be very, very smooth. You want to make sure that their left internal rotation on their hip is improved and their right external rotation on their hip is improved. A deduction of the shoulder on the right is going to be stickier than the left. But ultimately, I think the big boys, the ones that we really want to make sure are clear on both sides. And ultimately, you're always going to have a little bit of a discrepancy between the left and right side. So I don't think the goal should be 100% asymmetry. I think it should be like asymmetry plus or minus like 5 degrees. Like I think that would be, or even like sometimes 10, just depending on the person. But 5 degrees is usually a good landmark there. So I think shoulder flexion being symmetrical is huge, or mostly symmetrical is huge. I think obers being mostly symmetrical is huge, and hip flexion, and also straight leg raise. If I wanted to make people mostly symmetrical on things, it would be those.
Question. What if somebody is a narrow ISA, but they do not like fully, they don't fully pass like all their measurements, and they can't skip over like phase 1? That's an indication they have tertiary compensations.
Say that one more time.
Okay, so you said that someone who like has the only time like you wouldn't go through like a phase 1 if someone has a narrow ISA and passes all of those tests, correct?
Mm-hmm.
So what if somebody is a narrow ISA, they don't pass those tests? That's an indication there is tertiary compensations.
Yes. Well, I would say secondary, potentially tertiary, probably more so secondary, but I would say if they're like real locked up and they're narrow, they're probably pushing towards tertiary. But if we remember tertiary sometimes, in fact, let's just pull that up because I think that would be a good way to talk about it.
Oh yeah, purchased.
You got it?
Got it.
Nice.
There's only one left, y'all.
Yeah, honestly, you guys should give that book. It's really good. Where am I? Okay, here we go. So tertiary compensations, I mean, remember, the deeper they get, the more they start to look the same, right? So what you are probably going to see is all these things are really, really poor, but sometimes you see that straight leg or that supine knee to chest, which is like, whoa. So in that case, that's one thing that could lead you to say, hey, are you just primary and you have a couple of crazy things going on? But no, I think that's an indication they're tertiary because that doesn't line up with what the rest of these things are doing. because usually shoulder and hip flexion are relatively similar. If there's a massive discrepancy, you know that something's going on. And then these people will also just present with like ridiculous visual posture most of the times. And they will also present with often a lot of pain. So that's when you kind of know they're tertiary there. But you know, the wides and the narrows, they're going to end up looking, this is sway back posture pretty much.
And I have another question. What source can we consult to get better at visually identifying like, you know, that person's in like heel strike, or that person is in toe off, or like that person is, and what do you, because like I'm gonna exhaust my clients from like sending me like photos of themselves, and they already think it's kind of weird. They're like, do you have some like strange like OnlyFans account that you post these pictures to? I'm just like, no, I promise. I'm like, this is so I can learn. And so I'm going to exhaust my clients from doing that, and I don't want to do that. So what other resource can I consult in order to get better at my visual like postural assessment?
You know what we could do if there's enough interest, because like honestly the answer to that question is like what you really need to do to learn would be to, you know, have feedback, like actually look at a bunch of postures and then have feedback. What we could do is we could just have a call or a chat where we just sit down, like we all just look at each other's posture and we all just walk through it. I mean, if there's enough interest for that, I'd be more than happy to help you guys do that.
Yeah, that would be awesome, because I want to sharpen those, like that I really want to sharpen that skill in order for me to better and more accurately and to more effectively, more quickly form someone's program.
Yeah, well, shit, let's do it then. I'll put it in the Slack chat, and I'll put a straw poll for a time. I'll throw out a couple times, and we'll do it.
Okay. Thank you so much. Thank you.
Of course. All right, guys, let's one more question and let's wrap.
Yes, sir. I've seen a couple books on biotensegrity. I just got one on my Amazon cart right now. It's by let me tell you real quick. This one is by it's called Biotensegrity, the Structural Basis of Life by Graham Scarr.
That's the one I have.
That's the one you recommend?
Mm-hmm.
And yeah, you'd recommend getting it? Like it's
100%. Yeah.
Okay, great, cool.
Super good. Yeah.
All right. Cheers, man. Thanks.
Of course. Any last closing thoughts? Oh, hang on, Ryan. I just saw your question. Does ipsilaterally loaded stuff bias more ER? I've been doing, especially for hip IR. So it biases if you're going to do a hinge, it's going to bias, well, really in both circumstances, it's going to bias you driving more IR, because you can shift into that side easier on the way down, but you have to then go and propel back into ER from there. So ipsilateral load is good for promoting late stance mechanics, because you have to push out of IR into ER, but it's also a little bit of mid stance on the way down. And naturally, as you go down into hip flexion, deeper levels of hip flexion, you're going to be in IR anyway. So I think if I wanted to give someone more late stance mechanics or transition them to push out of IR into ER, ipsilateral load's a good way to go. All right, guys. Well, I will post that thing in the Slack chat right now with some times. And then I'll talk to you guys on Monday. I hope you have fun with the case studies. See you guys later.